Welcome everybody. My name is Reema Patel and I'm one of the president of the Global Anesthesia, Surgery and Obstetric Collaboration. Welcome to our event today on Frontline Global Surgery 2. So this is an event which is a follow-up event from one of the events that we had last year. Promises to be an exciting few hours with some fantastic speakers. Noel.
Thanks very much, Reema. My name is Noel Urupral. I'm the past president of GASOC and one of the event organizers for this Frontline Global Surgery event. We are so excited to welcome you for our half-day virtual webinar on Frontline Global Surgery 2, the road to universal health coverage. So as Reema has already mentioned, last year's Frontline Global Surgery Conference indeed was a huge success. We had a lot of participants where we discussed how viral outbreaks have affected surgical anesthesia and obstetric care. So this year we want to discuss the impact of COVID-19 on SAO care in LMICs and how we can still achieve the UHC vision by 2030. As you know, UHC emphasizes not only on what services are covered, but also how they are funded, managed, and delivered. So this event plans to highlight the devastating effects of COVID-19 LMIC and generate an advocacy drive within the global surgery community. I know we won't have all the answers after this webinar, but at least we will have some pointers that we can take home with. We've partnered with Incision UK and collaborated with the G4 Alliance, RCSI Institute of Global Surgery, BAPU, and ACID for this event. So with further ado, I want to invite our first speaker, Professor Anita Gargill. So Professor Gargill, she is the head of Department of General Surgery at Baba Atomic Research Center Hospital, Mumbai in India. In addition to her work as a general surgeon, her areas of interest are burden of surgical disease, surgery in limited resource settings, and breast cancer early detection and epidemiology. Professor Gargill has worked widely towards providing comprehensive cancer care near people's home at secondary level care hospitals. As the head of WHO Collaborating Center for Research in Surgical Care Delivery, she leads and coordinates various multi-center teams working in the field of surgery in limited resource settings. She also leads a multi-specialty research group called Thursday Truth Seekers, affiliated with WHOCC, to facilitate and coordinate research in various health-related topics ranging from public health, maternal and child health to health economics. She also has international academic and research collaborations with International Agency for Research in Cancer, other WHO collaborating centers, Karolinska Institute and Ministry of Health in India, as well as CRO countries like Bangladesh and Nepal. We welcome you, Professor Gargill, and over to you.
Thank you, Noel, for your kind words. And thank you for inviting me here. So to let me know if the presentation is not visible, otherwise I assume you can see it. Yeah. So good afternoon, good evening, everybody. And today we'll be speaking on effect of COVID-19 crisis on surgical care delivery in India. And does it change anything in global surgery? That aspect also very briefly. So usually health agenda in crisis situations like earthquakes, conflicts, wars, etc., that is driven by focus on injuries and surgeries. So surgical needs are prioritized, and in fact, surgical services systems are prioritized and strengthened. Whereas here in Ebola and COVID-19, the infectious diseases pandemics, the surgical agenda takes backseat and already frail systems break down. The already existing inequalities in access, availability, even in the most normal circumstances, they get exaggerated and they get enhanced. So with this background, we did a study of effect in, excuse me, are you able to see the screen, or is there any disturbance of the speaker window?
No, you can see.
Okay, thank you. So we wanted to quantify how much it has affected the surgical care delivery in India. So we formed an in-search collaboration, that is a collaboration of various academic institutes and medical colleges in India. And we tracked the pandemic as to how many cases are happening and how it is correlating with the COVID cases. So we found that when the lockdown happened on end March or beginning of April 2020, there was a complete paralysis of the systems. There was lockdown, there was initial panic, nobody had experience of handling these cases, all the resources were diverted, and the cases hit the rock bottom. As the pandemic cases reduced and the cases declined, the access improved. The surgeons, anesthetists, healthcare workers adapted the new normal. That was, they could handle the cases much better, and surgical cases started limping back. So as you can see, there is a pre-COVID peak, the pre-COVID normal, the previous normal, and now the COVID cases. Even when the COVID cases, even before it started spreading, the panic was so much that the cases hit the rock bottom. Eventually, after the September peak, when the cases started declining, the surgical services kind of started limping back. That is how, in this graph, the blue graph is the cases of COVID cases in India, and the red line shows the what cases we tracked, the surgical cases that happened. Yeah. So the Indian scenario, the surgical volumes overall reduced by 72%. Essential surgeries reduced by 52% and elective surgeries by a whopping 91%. That was partly by design because government had asked us to stop the elective surgeries, but we never expected that essential surgeries also will reduce by almost half. The priorities were obviously redistributed even within emergency and essential surgeries. As you can see in the graph, the cesarean section marginally reduced by 30%, whereas surgery for fractures, drainage of abscesses, laparoscopy, laparotomies, they all reduced by 70, 80, 90%. Other orthopedic surgeries from India reduced to around 60, 70%. That's how the one of the studies in India has documented. The Global Search Collaborative that have documented that there's 81.6% drop in surgeries globally. Now, talking about essential surgeries, this is something which everybody is familiar about. This is controlled priorities. They have described 44 essential and most cost-effective surgical packages to reduce burden of surgical diseases and avoid tallies. And these are to be done at the secondary care and district hospitals in limited resource settings. These are some of the conditions that they mentioned, surgeries that they mentioned. It has appendicectomy, it has gallbladder surgeries, hernias, cesarean sections, everything. But within these surgeries also, the reprioritization happened, as I mentioned before. Cesarean sections didn't reduce so much, but whereas other surgeries reduced a lot. Not just surgical services, anesthesia choices and challenges, that also changed. Anesthesia and COVID-19 posed unique challenges to patients and healthcare workers. For patients, the pneumonia, aerosol generation, the intubation of the airway would exacerbate all their pneumonias. And the regional anesthesia, whenever feasible, was the preferred mode. We documented that there was about 13% of reduction in general anesthesia. Laparotomies, what we call as awake laparotomies. Laparotomies were being done under regional anesthesia, which was not known before. So not known as in it was not so widely practiced, but this happened during COVID pandemic very prominently. In India, we saw the anesthesia change only 13% because a lot of places regional anesthesia expertise is not there. So general anesthesia we could not avoid everywhere, but yes, there was a drop of 13% in general anesthesia. So what were the challenges that we faced? The challenges in performing surgeries for COVID affected patients developing surgical conditions like soft tissue infections, abscesses, hematemesis, Now, some hospitals were completely COVID hospitals, called COVID dedicated hospitals. Now, they didn't have all these incision drainage, even smallest of the surgical facilities, endoscopies, or any other advanced surgical facilities obviously were not there. So the multi-speciality module or multiple departments seeing patients, which is prevalent usually, did not happen. They were locked in there in the COVID hospitals, and it was very difficult to manage these cases. Similarly, patients admitted with surgical conditions, when like appendicitis, like cholecystitis, when they developed COVID, the staff there was not prepared to handle that. They were in a normal ward. And then there was a huge exodus. A lot of people had to be quarantined because they were not vaccinated that time. Similarly, post-operative complications and pneumonias in co-operated patients were very common. This times, not just patient, but the surgeons were also at risk. So that also determined the priorities, not just from the DCP3 point of view or whether this surgery is essential, non-essential, not that, but even whether it is a risk to how much of a risk it is to healthcare workers, even that determined the priorities. So as Hokon et al. Have seen in one of the papers from Ebola pandemic, they have titled this paper, "For this one, let me take the risk." And this is a quote by a gynecologist where they say that, okay, this is important, so let me take the risk. So it affected already low workforce that we had. And in India, 1,000 doctors, more than 1,000 doctors died since the pandemic. And out of that, 25% deaths were since April 2021, that is just in last couple of months. This has been the devastation especially by the second wave in India. So because of this prioritization, reprioritization, risk to patients, risk to healthcare workers, a new normal emerged. So what is the new normal in surgical care delivery? What will it be? So it changed protocols like oncology, oncosurgery. Sometimes instead of surgery first, people started giving chemotherapy first, trying to postpone the surgeries, give it a new adjuvant, and then operate. So many protocols changed. Similarly, indications changed. Conservative management of appendicitis would get operated within hours. Cholecystitis would get operated within same admission. But these conditions got conserved. The priorities was given to something else, the cesareans, the open fractures, and so on and so forth. The laparotomies, some of them took a back seat. Similarly, anesthesia preference, awake laparotomies, as I mentioned, that was a new normal. Then priorities, how the priorities changed. First, we had essential surgeries to guide us, but now the NHS document defined, or rather redefined, what is urgent. They had classified the surgeries, as you can see on the left, that priority 1A, 1B, these were the surgeries which had to be done within 72 hours, 24 to 72 hours. Level 2 surgeries up to 4 weeks, and level 3 were up to 3 months, and level 4 surgeries which could be delayed even more than 3 months. So in Surge Collaboration study, which we did, we saw about, in category 1, we saw about 53.5% reduction, whereas the rest of the surgeries, the reduction was quite a lot. That's up to 90 to 95%. That means surgeries which could be postponed by a month or 3 months, they got postponed. Now we don't know how long they got postponed, whether they really got done within next few months. We will not know probably, or it will take a long time. How many hernias got incarcerated, obstructed, strangulated, how many gallbladders perforated, and so on and so forth. That will take time to understand that effect. But it redefined the urgency of the surgery for sure. Local surgery nationally, yes, what happened was, just to see the overall perspective within the nation, not just about our study or what we captured, usually in this setting, the HIC, LMICs, all of them got converted into limited resource setting, but because all health systems were overwhelmed. So each one had to look after their own health system. Now no one was going to come for help. So how did we stand up for the challenge? We had dedicated operation theaters for COVID patients, dedicated workforce in rotational duties, rapid testing, provision of PPE, and most important was adhering to guidelines. I was most amazed. In India, and more or less in a lot of LMICs that I have visited so far, it's very difficult to adhere to guidelines, usually because of the resources, because of the mental makeup. People are not ready to adapt to new things and changes. But here, the adherence to guidelines was quite remarkable. The task shifting, task sharing also happened. Freshly passed MBBS non-specialist delivered the specialized care in proxy. The most important thing that happened was e-health or m-health, specialist opinions, e-roundings, especially where the limited access is limited even in routine times. This would be very helpful because the red zone where the patients are, not all specialists would go, but the residents or the doctors who are on duty would use a dedicated mobile, show them the patients, tell them the parameters, and e-rounding was done, specialist opinions were done. And I think this would be a new beginning, especially in a country like India where access is very limited. Intensive care went beyond intensivist and to generalist to quite some extent. I don't think this happened so much in HICs, but in LMICs, yes. The doctors, the normal MBBS doctors, non-specialized people did learn part of intensive care, to how to put the patient on BiPAP, how to put the patient on ventilator. Some of them, till the intensivists came and took over these cases. These cases were handled by even surgeons, by normal doctors. So this was something very new. Innovations and what we call in India jugaad that happened rampantly, and I hope that it kind of became a part of mainstream medicine. Internationally, what happens is in other crises, there's international teams happen, support teams comes, partnerships, like disasters or conflict. This did not happen. The borders were sealed, nobody was coming. So that international team kind of working together, that didn't happen. Surgical missions, which are there in routine times, those did not happen. Usually in peacetime, the international fellowships for global surgery students, global surgery also got quite affected because these fellowships, nobody went anywhere. People who wanted to travel to LMIC for research, for field visits, all that got cancelled. Research by primary data collection, it didn't happen. A lot of research changed to secondary data collection or systematic reviews or survey studies and so on and so forth. Electronically, the primary data got collected, if at all. And that became the norm because the amount of surveys, as you can see in your email and your WhatsApps, it comes every day. It's phenomenal. This has never happened before of this magnitude. And of course, conferences and all meetings happening like this one happen on web platforms. Now, again, this might be the new normal. So from the effects of COVID-19 on surgical care delivery in India and global surgery on a larger picture, the global surgery, the surgical volumes in India reduced by about 72%, essential surgeries reduced by 51%, and elective and non-essential reduced by whooping 91%. Prioritization happened within essential and emergency surgeries also. Which cases to operate, when to operate, whether to operate at all or not. For example, C-section reduced only by 30%, as I said, whereas fracture surgeries, laparotomies reduced by 70-80%. Treatment protocols changed, anesthesia practices modified to reduce risk to patients and healthcare workers. And this might continue, and hopefully this will continue to have less risk procedures in anesthesia also. Surgical training within country and internationally, global surgery research, collaboration, surgical missions, as I mentioned, affected very adversely, but stabilized eventually with telemedicine and electronic platforms, which are going to become the way of life, is what I think. So this is the place I'm speaking from. Our Mumbai city in India looks beautiful when it's in lockdown, no traffic. So, and this is a place where I live. So thank you and happy to take questions. These are the references. Thank you so much.
Thanks very much, Prof. Gargill. That was a fantastic talk, and there's so much to learn from what you've delivered today in your talk. So I'm just going to take some questions. So just request all the people who are attending, please put your questions in the QA box. We've got one question from Natalie Shannon, and she asks, Dr. Gargill, in your opinion, to what extent is the upskilling of generalist practitioners in intensive care potentially valuable beyond the pandemic? So do you feel that this has strengthened the workforce for intensive care, perhaps in other skills like leadership and decision making? Thank you. Thank you, Natalie, for that question.
Yeah, I think that's a very good question, because we don't have so many specialists, so many intensivists proliferating everywhere. They are in a restricted area, mostly in cities, and no access to rural population. Even within cities, the access is not there of these services, sometimes in secondary care hospitals. Or even if it's there, the volume versus the patient volume, it's quite disproportionate. So using these new courses, workforce people like past MBBS past doctors, or even people who were not doing intensive care before, like surgeons, like they are used to taking care of patients, but not exactly doing intensive care all the time, or not doing it full time. These people were brought in and taking decisions. Now patient needs intubation. Intensivist is taking rounds somewhere else. Now patients are overflowing. You have to take decisions. So people stood up for the challenge, I feel, and then or started them on BiPAP. They started decision making. They started following certain protocols, because it's always risky to suddenly take decisions which I have not taken for so long. So I might as well stick to some protocol. That's how the adherence to guidelines also came. So this is going to proliferate it into a lot more in terms of workforce strengthening. Yeah, I think there is a chat that we are doctors before specialists, and we should be able to, yeah, this precisely. I mean, if patient is dying, you can't wait that I don't know how to keep, whether to keep the positive airway pressure at 5 or 10 or 15. I would at least start high flow oxygen, take some decisions which I can take within my, even if for a junior doctor. That was the point. Thank you.
Excellent. Thank you very much for answering that question. I have a question for you, Professor Gargill. So you mentioned about the surgical volumes that has reduced during the COVID pandemic, but you particularly talked about essential surgical procedures. And how do you think, as these procedures have been more than halved, isn't it, 80 to 90% reduction in these procedures, how do you think it is going to affect the universal health coverage for these essential surgical procedures in the next 10 years leading to 2030?
Yeah, I think it would be great if I don't have to answer this question, because nobody really knows. It's scary even to think of how to answer this question. I mean, I don't know how many breast cancer patients are going to come to me with locally advanced breast cancer, with fixating the skin and huge axillary masses. We will not know people who don't even reach, because that's another big problem in India. So how many people died of incarcerated or obstructed or strangulated hernia, we would probably never know. I don't know, but probably when the population-based surveys like NFHS 5, what we call National Family Health Surveys, maybe the next rounds, the one round just came in 2019, but when the next round comes, maybe we'll get a glimpse of it. I am not sure whether we will really understand how it affects, but it has taken a huge amount of setback, especially from access and presentation point of view. I'm scared to even think about it.
Yes. Yes, and it's interesting, isn't it? Because essential surgical procedures, sometimes we talk, or at least I talk from a perspective of people who are in the rural healthcare setups. Exactly. But this COVID pandemic, especially the situation in India, it has just not affected the people who are in the rural settings, but also people who are in the urban settings. So I think this probably highlights the importance of essential surgical procedures once again. And I think from a health system point of view, the government needs to put in a lot of funding to support these procedures, so that these procedures can happen essentially in the next 5 years, and you can pick up the backlog. So one last,
yeah. No, I'm already holding my head every week now in Operation Theatre, because the lockdown is not yet out. It's just cases are reducing. People are feeling little safer with vaccination and reduced cases to move out. And already the cancers and the diabetic feet patients which we are seeing is already very horrendous picture. I tell you, or operation lists are already getting depressing.
Yeah, so although the COVID numbers are coming down, the need is increasing, and the capacity is reducing because of what has happened. Great, I've got one more question before we move on to our next speaker. And this is from Ryan Ellis. He says, the development of awake laparotomy is fascinating. Do you think an innovation such as this will have benefits beyond the pandemic, in turn leading to greater focus in training in regional anesthesia? And what can be achieved with these techniques? Thanks, Ryan, for that question.
Yeah, I think that's an excellent question. Maybe the anesthetist on the, I think Mahalit is an anesthetist, so she'll be able to tell. And I'm one of the fortunate few to have a very good anesthesia backup team. So I guess it is very skillful to give anesthesia, like regional anesthesia. It needs a different set of skills, probably different set of instruments to locate the nerves and locate where you want to inject and all. Although I'm not an expert, but awake laparotomies, similar to that, unilateral spinals, regional blocks, this has become the norm. We have like 85-year-old, 85-year-old having perforated appendix or having some other island perforations, which we had. I'm just telling you from personal experience of last few weeks and months. We happily managed that on epidural and spinal. And for anybody above 80 or 70 and who is even remotely frail, I would definitely, even after pandemic, would want to do that with my anesthesia support. Thank you. Yeah.
Fantastic. Thanks very much for answering that last question. Thank you again for speaking at this event, and we'd love for you to stay with us and participate in the Q&A session at the end of this webinar. So thank you very much, Professor Gargill.
Thank you, Noel, and thanks for taking the questions for me, because I was not able to see the chat box. So thank you. If I've missed anything, do chat back to me and I will be able to answer them. Thank you.
Thank you very much. Okay, we'll move on to our next speaker.
So our next wonderful speaker is Dr. Mahalit Tadessi. She is Assistant Professor of the Anesthesiology Department and is a Cardiothoracic Anesthesia Fellow at the Tikur Ambasar Specialized Hospital. She is the current president of the Ethiopian Society of Anesthesiologists. Dr. Tadessi has extensive training in simulation and critical care, has worked with the Ministry of Health to increase capacity of anesthesiology residency program in Ethiopia, and has recently worked with Lifebox on the guidelines on COVID-19 preparedness within the surgical, obstetric, and anesthetic ecosystem in sub-Saharan Africa. So Mahalit, it's wonderful to see you again, and over to you.
Okay. Thank you, Rima, for the very kind introduction. I'd also like to thank the organizers of this conference for inviting me and for giving me this opportunity to share my experiences from my country. So let me just share my screen. Okay, so I'm going to be covering about the perioperative care during COVID-19 in Ethiopia. So I have 15 minutes and I'll try to cover as much as possible. So I'll just try to give you a highlight about the overall COVID-19 spread in Ethiopia, try to see some of the surgical and anesthesia capacity in Ethiopia in the pre-COVID state and in the past year and try to see the impact of the COVID-19. And I'll try to identify some of the challenges we faced and some of the opportunities we were afforded, and try to look at the way forward. So just to give you a highlight, so for those of you who are not exactly sure where Ethiopia is or who might need a reminder, it's a big landlocked sub-Saharan Africa located around the eastern part of Africa. It's a large country, the second most populous country from Africa, following Nigeria, and the 12th most populous from the world. We have a population around 170 million, high growth rate of 2.53%. And it's a young population with more than 40% of the population being under 15 years of age, and only around 3% of the population being more than 65. So just to see about how the COVID situation was in Ethiopia. So the first COVID state was reported on 13th March of last year, and since then, as of yesterday, 4th June, we have seen 272,000 confirmed cases, and with around 4,185 deaths. So currently, we have around 23 active cases. When we look at the death toll, it's around 329. It's around 36 deaths per million, and we have around 329 patients who are in serious or critical states who requiring hospitalization. And when we look at the vaccination states, we're still heavily dependent on donations, and we're still way behind for vaccinations, with around 1.8 million first doses being given as of May 31st. And of course, priority was given to healthcare workers and to those people above the age of 55. And just to show you the trends, it was very slow in its progress initially, and then around the summer of last year, around June, July, August, we had our first peak, and then there was a decline followed by the second wave which was around a month or 2 months ago. And the days toll also corresponds with the two peaks. So when we look at it in terms of from Africa, we account for around 5.6% of the total COVID cases in Africa and 3.1% of deaths in Africa. And we have a case fatality rate of 1.7. So Ethiopia, like other low and middle income countries, we have faced significant challenge in our response to the COVID-19 pandemic, primarily stemming from resource limitations. So just to mention some of the few challenges we faced as a country. So initially, to start with, we had a very poor healthcare system. So with very significant shortage of healthcare workers and poor health infrastructure. So even though in the past 2 decades, the government has been actively working to improve this, and we were just a work in progress. So it has at a really bad time. So other factors, we have high literacy, low awareness of the disease and its prevention. We had lack of skilled health personnel, more specifically working in critical care area. We had very scarce intensive care units and mechanical ventilators. And Ethiopia, we had a double burden of the disease. We have both infectious disease as well as the non-communicable diseases. So these were some of the challenges we had faced. And considering all these factors, initially we had feared a big catastrophic incident, but fortunately it was not, the death toll was not as catastrophic, especially when you compare it to other developed countries. And there were some factors which provided us some optimism and some reprieve. So this would be like most of our population is a young population with low risk for more severe forms of the disease. And another good thing is we had a delayed pandemic surge, so this gave us some time for preparation. So in that time, we tried to increase our capacities for ICU beds, for ventilators, optimized training. So we used global experience and knowledge from other places, and we used that time to also raise public awareness. So because of all this, our death toll was not as significant. But of course, we cannot deny the significant toll it took on our growing health system and overall the country's economy. So I'll just like to start, when we come to the surgical anesthesia capacity in Ethiopia, I'll just like to start by giving you a highlight of the state of surgery and anesthesia in low middle income countries such as Ethiopia. So as you know, we have lack of safe surgery, and anesthesia is one of the big burdens we're facing as developing nations. And the good thing is safe surgery and anesthesia is increasingly being recognized as an integral component of global health efforts. So the recent Lancet Commission report, the Global Surgery 2030, estimated that 5 billion people worldwide lack access to safe surgery in anesthesia practice. And as much as 30% of the total global burden of disease could be treated with surgery. And what the report has also shown us is that there's a great disparity between developed and developing nations. And currently only 6% of the 313 million surgical procedures performed each year take place in low middle income countries where more than 1/3 of the population lives. And we look at the death toll is significant again. Surgical conditions, they kill more people each year as compared to HIV, AIDS, TB, and malaria combined, with each year an estimated around 70 million people dying of preventable surgical deaths. And in Eastern Sub-Saharan Africa, again, it's the same. An estimated 21.5 million procedures would be necessary to meet the current burden, but only 4.3 million performed. And when we come specifically to Ethiopia, in Ethiopia, total surgery done is not more than 200,000 per year. And this is significantly inadequate to reach the unmet need of 5 million surgeries per year. And waiting time may extend up to 4 to 7 years, especially in the referral centers. And so when COVID hit in 2020, it created a significant hurdle on our already dire state of surgery care system in our country. And overall surgery during COVID-19 pandemic, it was challenging globally, but this was especially more magnified in low middle income countries in which the limping healthcare system was broken, with even more lack of access to surgery caused by the increased cancellations. So just to show you the graph for our country, in Ethiopia, we had significant increment in delays and cancellations of surgery, and we're still seeing this effect way into the second year of the pandemic. So as you can see, in the elective surgery, we have faced up more than 25% decrement in elective surgery when you compare the 2020 rate of surgery with the pre-COVID state. And even in emergency surgeries, we have faced up to more than 75% decrease in the amount of surgeries being performed. So what were the challenges we faced in our perioperative care during COVID-19? Of course, like everywhere else, one of the big challenges was protecting healthcare workers and protecting our surgical patients. So there are many factors contributing to this, like low and lengthy testing capacity. So our COVID tests, they usually take time. So even though in order for the patient to be admitted for surgery, they required COVID tests, but these COVID tests are usually done once the patients are admitted. So the patients had to stay in the ward in a crowded room while waiting for the test results to come. So this also created a big problem. There we had lack of personal protective equipment, lack of anesthesia emulsion filters. We had limited isolation capacity, especially during the second wave, when all the COVID centers and all the isolation wards were full. We had to treat patients who were COVID positive right beside the normal COVID, right beside the normal patients, both in the wards as well as in the ICU. So this was another very big hurdle we faced. Again, limited vaccination capacity, poor infection prevention practice even. And the other thing we're starting to see, especially nowadays, is caution fatigue, both in healthcare professionals as well as in the patients and in the general public. People are getting tired of all the precautions they've been taking for the past 1 year, so they're becoming more careless. The other challenge, lack of surgical and anesthetic medication, was also one of the biggest challenges we faced. So these are multifactorial, one of the reasons being financial constraints of the hospitals, of our regions, of the governments. This is just can be explained by the overall impact of the pandemic, which hit our economy badly. But not only that, even when there is money available, there was interrupted global supply chain. So there was lack of specially anesthetic medication equipment, which were also being used in the ICU. There was significant shortage in the market. The other big problem we faced is lack of oxygen. So we saw this especially during the second wave, because when the oxygen demand significantly increased, and to make matters worse, the big oxygen plant, one of the biggest oxygen plant failed. So for a few weeks, we had to totally close off all our elective surgeries in order to save the oxygen for the COVID patients. And on top of this, we normally in the country, we have a wasteful use of oxygen in our OR setups, because almost all ORs and anesthesia machines in the country, they use high flow oxygen, and they use 100% oxygen for all their OR and anesthesia cases. So as you can imagine, this is significantly wasting precious oxygen. So overall, all these challenges I've mentioned, they led to high cancellation of elective surgery. And there was a significant delay in the care for urgent surgery. So just to give you the surgical backlog in the pre-COVID state was around 12,000 people waiting for surgery. And with COVID, we had an increment around 27%. So now it's more than 60,000 people, 16,000 people are waiting for surgery. So this is a significant number. And other factors is there's a reduced healthcare seeking behavior from our patients. So most of the time they present to us in a fairly progressed state of disease. The other problem was we had fear of infection among staff, which created poor patient care and poor quality patient care. The other, as I mentioned, our COVID testing facilities were not optimum. The other thing, just to mention a few highlights about challenges faced during this pandemic on our teaching, there was disruption of residence teaching, compromised quality because of the low OR caseload, low variety. There was delayed recruitment of residents. We had to suspend teaching and learning activities with international faculty. So this was even more of a problem for the new residency programs and for the few fellowship programs we have. We have cardiothoracic and we have
Mahalit, are you still there?
We're having to face new situations, unexpected situations where we had to make decisions. And this created a lot of confusion between the staff, a lot of arguments and miscommunication between the different disciplines and the staff. So again, this was one of the big challenges. For example, during earlier in the pandemic, there was a big problem and a big confusion as to how to deal with COVID patients who have recovered from COVID, but who are waiting for surgery. Do we delay them? To how long should we delay them? So there was a lot of confusion. And other things, for example, when the ORs become accidentally contaminated, or when our anesthesia machine or where our mechanical ventilator becomes accidentally contaminated, how do we proceed? So these were some of gray areas where there was no adequate evidence or experience. So it was a big challenge in dealing with these new situations. The other is the psychological impact on staff. Again, was also significant. So with high depression and anxiety, burnout, and overall lack of psycho and social support for both the patients as well as for the healthcare workers. And this is one of the areas, mental health is one of the areas which is usually ignored. So looking back on this 1 year, this pandemic has paved the way for some opportunities. So just to mention a few, it has increased awareness in our infection prevention. It has increased the interdisciplinary collaboration. It has made way for innovation and research. It has increased number of ICUs and ventilators, and overall the investment in critical care has significantly increased. We have increased the awareness of anesthesiology in critical care field among the public as well as the health policymakers. It has also provided us a platform for us as anesthesiologists to be recognized as our role in our leadership, health system management, and health policy development. To see the opportunities it created in teaching, the increased interest in the field of anesthesia and critical care. We managed to open 3 new anesthesiology residency programs in 2021. We've increased incorporation of e-learning methods in our normal teaching methodologies. We have broadened opportunities to attend international conferences such as this one. We have enhanced experience. It has enhanced experience of dealing with challenging group of patients, including improved practice of mechanical ventilators and use of ultrasounds in the ICU. So what's the road ahead? So moving forward, we have to use the opportunity to redesign our surgical pathways to deliver quality perioperative care and provide timely access to safe surgery and anesthesia. So our aim would be to reduce the surgical cancellations. We have to reduce our surgical waiting time, reduce the length of hospital stay. So all this, they have worsened during this past one year. We have to improve our post-op care and rehabilitation, and we have to reduce the per capita cost of healthcare through improving value and through minimizing wastage. So just as a way forward to summarize.
Right, Dr. Tadessi, that's just coming up to the last couple of minutes. Thanks very much.
Okay.
Oh.
Am I
Dr. Tadessi, finish your last slide.
Yes, it is interesting.
Yes, okay, this was my last line. So as the last way forward, I would just like to, we have to improve our efficiency of surgical patient flow. We have to improve our team working and embed shared decision-making for effective patient-centered solutions. Standardization of process, we have to strengthen that. We have the other very important thing we have to work in the country is increasing use of day surgery. We have to promote healthy living and prevention of ill health as part of the perioperative care. We have to protect our patients and healthcare workers against COVID and provide psychosocial support. And also, we have to work in providing equitable and global vaccine distribution. So thank you very much.
Thank you so much, Dr. Tadessi. That was a wonderful and insightful summary on what's happened with regards to COVID-19 in the last year in Ethiopia. There are a few questions and comments in the chat box. So first of all, we have a question from Mohammed Mofate, who said, do you have some estimates on how long it would take to clear up the cancelled surgery backlog? And are there any measures that you've taken to speed up the process at present? I think Dr. Tadessi has frozen.
Sorry.
Oh, go ahead.
Okay, sure. Yes, so the waiting time has, even in the pre-COVID era, it was long, especially for some specific kind of surgeries, for example, for orthopedic surgeries, for cardiac surgeries, for neurosurgeries. So it was already long as it is. And now with the addition of COVID, so usually it might range up to 4 to 7 years, but it depends upon where the patient is getting service. Is it in the urban area? Is it in the rural area? In which city it is? So depending upon where this patient is located and depending upon the kind of surgery the patient wants, it might extend even up to 7 years.
So actually following on from that, thanks, Dr. Tadessi, we have a question from Natalie Shannon again, who said, where do the estimates from the surgical backlog in Ethiopia come from? How are these numbers being tracked? And do you think the burden of unmet surgical need may be higher than the estimates? Okay,
so the good thing is our health minister has taken a great step in incorporating surgical care in the universal health care for the country. So starting from 2015, there was a big plan. There was a directorate recognized just to provide the effective and safe surgery for the population. There was a roadmap for surgical service, anesthesia, obstetric, and all for the essential surgical services. So this directorate, it's the one who traces the data and who follows this. So I got my data from the Ministry of Health, and of course there might be underestimation of the numbers, but the Ministry of Health has taken a great lens into ensuring that enough focus and energy is being invested in safe surgical practice. And our main area goal is, of course, to minimize this waiting list, and to optimize. We have a lot of wastage when we consider our current practices. There's the length of stay of the patients once they are admitted is significant, and the delay of surgery. So there are lots of factors. It's quite difficult to just summarize it in this 15 minutes, but we're working on it.
Thank you. And thank you, Natalie, for that great question. There's been a few comments, or quite a lot of comments actually, on the fact that you've mentioned the effect of COVID on the mental health of workers that have been interacting with such patients. So Professor Gargill has said, thank you for touching upon the important aspect of mental support for healthcare workers. And Delphine has said, thank you for including the effect of COVID on mental health staff. Were there any initiatives that were set up within your local hospital or department to deal with the effect of COVID and dealing with these patients on the mental health of your staff?
Okay, yes. So that's one of the big areas where we are lacking in the country, in our society, in our hospitals. And so in my hospital, we are not a COVID center. So I work in the largest referral center in the country, but we are not a designated COVID center. We have totally dedicated another 2 hospitals for COVID care only. So I know for a fact that in those hospitals, there is a psychiatric service which provides treatment and support for both the patients as well as the healthcare workers. So I would say that was a very good step towards recognizing the role of mental health in our surgical services, even in the pre-COVID era. But still in our country and in overall, in our hospital, in most of the other hospitals, there's still not enough recognition to that. And we still have to work on that.
Yeah, I think that's one of the issues worldwide as well. Janan Malik has said they're experiencing very similar problems in Kenya with regards to in their residency. How has the effect on the residency program been managed from your perspective? I know you touched upon it within your presentation, didn't you?
Yes, so so unfortunately the residency program has been, of course, affected, and especially towards the start of the pandemic, our surgical case loads had significantly decreased. So almost there were months or weeks where we had very few cases. So this, you can imagine, this would significantly decrease the exposure of surgical cases to our patients. And on top of that, we had to mobilize our residents to cover COVID hospitals. So we had to send our residents as well as our staff anesthesiologists to COVID designated hospitals. So again, this also compromised with their normal rotation. But we are managing. And the other thing is we had a lot of programs with international faculty, because most of it's relatively a young field, anesthesiology, in our country. And we still rely on external faculty and international faculty. And we had a lot of programs, ongoing programs. So again, when COVID hit, it put a halt to all this. So there was, especially towards the start of the pandemic, of course, there was a lot of confusion, there was a lot of fear. So it was a bit of a a problem, but we managed, and right now I would say it's relatively going good. We have at least in our hospital, our surgical caseload has relatively returned to the pre-COVID area. And the other thing is, of course, if you see our ORs, because we have a lot of residents as compared to the actual OR tables and cases, we tend to have our ORs tend to be crowded. So in order to have the social distancing and to minimize the number of people in our ORs, we also had to decrease the number of residents. So there were a lot of problems, but we have come to a solution in most of them, and we have also identified some opportunities.
Fantastic. Something that I personally wanted to ask is, over the last year also, what have you taken away personally or learnt from what's gone on over the last year, from more of a sort of humanity perspective?
Sorry, excuse me?
From more of like a humanity perspective, what have you learned? What have you taken away from what's gone on in the world over the last year? It might not be the best platform to have this philosophical conversation.
Yeah, so I think each country took it differently. So in Ethiopia, initially there was, last year when the pandemic started, we were having very few numbers. I mean, for months up until July or August, we were seeing very few numbers and almost negligible deaths. But at that time, there was a lot of fear. So because of that, there was a confusion. There was, there were some, a lot of the action was taken during that time when the pandemic effect on the country was minimal. And now what we see is, amazingly, like the pandemic has reached its peak right now, especially around last month or 2 months back. It was like our ICUs were full, our mechanical ventilators were full. We were having patients, there was significant shortage of oxygen and patients were dying because of lack of oxygen. But even during all that situation, there was just, like desensitization. So people just, right now, what I can see is people have stopped taking precautions. So there is, of course, a universal mask mandate, but again, there's no enforcement. I mean, like if you choose to go out without a mask, then there's no one holding you back. And social distancing has almost completely stopped. Public gatherings have also started. So I think that's one of the big problems we're facing. People they're already tired of hearing about COVID. They're already fatigued of taking the precautions. So right now you can see we're lagging behind in our precautions. So unless and otherwise we get our vaccinations, we might be predisposed to another wave and see another catastrophe ahead of us.
I'm sure we'll touch on the vaccination aspect of things later on in the panel discussion, but there's one final question from Kefi Mubarak, who says, how has COVID affected research in your centre and what have you done to address it?
Okay, so I would say it actually brought upon an opportunity. So because there was a lot of things happening, there was so much we didn't know, and almost every question could have turned into a research. So I think it did open up the room for more research, and I think we did see more research being done during this past year. Yeah, so I would say it actually turned into a positive reinforcement.
Fantastic. Thank you so much, Dr. Tadessi, once again. I hope you'll stick around for the discussion later on.
Okay.
We'll move on to our next speaker now. Thank you.
Okay, thank you so much. Thank you everyone for your attention.
Great, thank you, Rima. And thank you so much to our two speakers that we've had so far. My name's Katya and I'm the chair of Incision UK this year. and I'd like to introduce now our student and trainee discussion. So we're really excited to have our 4 panelists here today. If our panelists for this discussion would like to turn your cameras on, that would be lovely. And so for some quick introductions, we have first Dr. Rohini Dutta, who is a medical intern at the Christian Medical College and Hospital in India. Dr. Priyansh Shah, who's also a medical intern at Baroda Medical College in India. Both Dr. Dutta and Dr. Shah are also global surgery fellows at the WHO Collaborating Center for Research on Surgical Care Delivery in LMICs. We then have Dr. Hung Wei Pin, who's completing his housemanship in Malaysia and is also president of Incision Malaysia, and Mr. Takut Singh Burjo, who is a 6th-year medical student at the University of Buea, Cameroon, and a research fellow at the Association of Future African Neurosurgeons. So thank you to all of you for being here. Just a couple of notes before we start. We can put questions and comments in the chat at any point, the panelists to reply to on there. And there'll also be a Twitter feed open for each question on the Incision UK account. So our first question is for Rohini, and that is, for Burjo. So the first question is, Burjo, how has your training been affected by the COVID-19 pandemic?
Thank you very much for the question, Katia. This pandemic has affected my studies in various aspects, which I'll group them into 2 groups, positive effects and negative effects. For the negative effects, the pandemic has reduced my contact with patients. You know, there's this famous quote by William Osler, which says, medicine is learned by the better of the patient. This pandemic, I had like kind of a reduction, like to be able to learn the practical skills to be a good medical doctor tomorrow. Also, I also faced some financial hardships. You know, my sponsors had difficulties due to the lockdowns, so as to help sponsor my studies. Also, the fact that I've been, at a certain point in time, I had to be in the house, you know, I became a little bit depressed, anxious. Also, my motivations were this kind of reduced. Now, for the positive effects which came into place, that is as a form of my personal adapting to what I mentioned earlier, this pandemic contributed enormously to my future career as a neurosurgeon. You know, I'm an aspiring neurosurgeon, and during the pandemic, I had the opportunity to actually start working with this wonderful organization, the Association of Future African Neurosurgeons, where I had the opportunity to be exposed to various neurosurgeons, residents, and aspiring neurosurgeons all over the world, where I had the opportunity to like learn from them, know the opportunities out there, and also had the opportunity also to discuss with other organizations such as NANSIC and the Dundee Neurosurgical Club. Nowadays, the ideal medical doctor is someone who practices the medicine, that treats patients, do research, and teach. So with the Association of African Neurosurgeons, I was able to learn that is, I've been working, like now I'm now a student who participates in certain research projects and also educate through webinars. Still with this pandemic, I've been able to get acquaintance to networking, online training, video conferencing. And lastly, due to this pandemic, I've changed to be from an ordinary student who is just learning to practice, but also I've also begun to be a student advocate of global surgery, global neurosurgery through Incision and the Association of Future African Neurosurgeons. Thank you.
Thank you, Burjo. That was really great to hear both the positives and the negatives. I think we often discuss only the negatives of COVID. The next question is to Dr. Hung. So because of COVID-19, we were often deployed in different places and our roles as trainees or students may have varied. So what was your experience? How were you deployed during the pandemic and what was your experience?
So thank you for your questions. In fact, at the very beginning of the pandemic, I was just finishing my final exam as a medical student. So I was in the transition between the student and to the trainee. for the FY1, as how UK system call it. So throughout these transitions, I'm actually involving in the research in the orthopedic surgery, particularly interested in the arthroplasty. And this field is actually dealing with most elective cases like the total knee replacements. And we have seen a lot of delay in the surgery processes, and that actually being delay our research progress in some way. And besides my commitment in research, I'm also helping with tackling the misinformations during the pandemic, where a lot of misinformation about COVID-19 was quite happenings in Malaysia and also in particularly in worldwide. So we are utilize the social medias to join the movement like a student against COVID in Malaysia specifically. So yeah, we're trying to promote what should we do and what is the information that is ought to be correct, and and try to clear the myths of all the misinformations. And also we noted that isolations actually create a lot of mental problems, and that's why we kind of promote the self-care during the isolations when the lockdown in Malaysia actually started. So I was also quite aware of this, and those are my personal commitments. And also we are not forgetting our career advancement and also surgical trainings, particularly in the surgical inclined career. So I'm also trying to prep the MRCS exam through all the online resources that we have, the EMRCS, etc. And also utilize our time because I was waiting to be a doctor. So our placements were actually being delayed because of COVID. And medical legally, we are not supposed to take COVID patients as our rank because we are just a foundation years one houseman. So that's why our placements actually being delayed. But eventually we get into the system as well. So throughout that period, it's more on the self-searchings and all the self-improvement period that we have. So thank you for your questions.
Thank you so much, Dr. Hung, for sharing your experiences with us. And it's been amazing to hear how flexible trainees have been all across the world during this time. We can definitely continue this discussion in the Q&A box as well, so please feel free, everyone, to put questions in there for all the panelists. So I'd like to ask our next question, and that's for Dr. Rahimi. And that's, so what are some of the long-term effects, in your opinion, of the pandemic going to be on medical and surgical education, or some of the effects you've even noticed so far?
Thanks for the question. I think the effects would be more positive than negative. When the pandemic hit, I, just like Dr. Weepen, I just started my internship, which is right after my final exams of medical school. That is a one-year internship. And I was really excited for my community medicine posting, where we get to go to rural areas and do work there. And I thought that if there are no patients coming to our tertiary care center, there would hardly be any patients coming there. But that experience was so good. And I even asked if I could stay longer because we got to see more patients there. And we saw that because tertiary care centers had shut their door for elective surgeries and even some for very essential emergency services, patients were trickling to these rural centers because those were the places that were providing hope. And after that experience, I saw a lot of trainees just wanting to go to these rural centers to work. And these are usually postings that people don't want to go because you don't get good accommodation there. But even this year, this batch of interns, they all want to now go to rural postings. At the same time, the fact that the medical education system was completely online, the batch before me, Priyan Shivan, I think he was also the COVID final year batch where all the classes were happening online. It was in a way helpful, but at the same time, I think it made medical students realize the value of clinical experience. No one likes going to the wards every day to take histories, and you kind of dread it. But when that opportunity was snatched away from you from COVID, you realize how valuable it is to actually go out there and get that experience at hand. So I think that the nurturing of your clinical postings from now will increase. And some of the medical education things like PowerPoints and all of those things, which are not very firmly incorporated in the Indian system, at least of this online teaching based system, that will get incorporated much more.
Thank you so much for that answer, Rohini. And it's really nice to see that all of you are highlighting a lot of the positives more than the negatives on that COVID-19 has had on surgical and medical education. And in that same spirit, I'll move on to our fourth panelist, Dr. Priyansh Shah. So, like I said, in the same spirit, now moving on to the question of what are the positives going to be about the pandemic? So what can we learn from the pandemic and take away moving forward in the future? What are some positives that you see?
Thank you so much for this question. So I'd again lean on more towards the positive about the impact COVID would have on our health system. And I'd say the biggest positive is now everyone, including the people who are not in the medical field, are aware about the burden on the healthcare system, are aware about the neglected diseases, are aware about the facilities that we can improve to improve patient care. So this was, a sort of wake-up call for a lot of people from the medical fraternity and from elsewhere. So with this, we've started rebuilding the rural healthcare systems, as Rohini mentioned, that right now most of the tertiary care centers were closed for surgery. So the burden on rural healthcare system was quite increased, but unfortunately they don't have enough facilities to handle these patients. So in fact, medical students like us in our organizations have started working on strengthening the rural healthcare system, where we're providing the diagnostic tools like pulse oximeters, ECGs, and X-ray machines, and connecting them with telehealth. So we don't have enough trained doctors who can go out to the rural, healthcare system and provide care to everyone. That is why this integration has probably, helped us leap a decade ahead in the evolution of evolution of the healthcare system of India. Because right now, the number of people that you see who are motivated and who want to help these rural healthcare settings has improved drastically. And we ourselves have taken up this project of providing ECG machines and integrating it with the telehealth medicine. So I think how this would turn out is people would now be more cognizant about the deficits and the needs of the healthcare system, and would not take it for granted. So I think in that way we have a bright future. This crisis, just hoping that this crisis ends soon, and with that we'll be able to work more on our health systems.
Thank you very much, Dr. Shah. And I agree with all of you. It's great to be focusing on the lessons that we can learn and what we can take from this. And sorry to flip the coin a little bit, but my next question to Burjo is, what are some of the flaws that this pandemic has exposed in our current training systems?
For that question, first of all, what I have to say is that the pandemic came as a surprise for everyone. So no one expected that. So the flaws, they are not many. The main problem was on the fact that the educational system was kind of like had the difficulties to implement online learning or to implement digital learning, and especially for the vulnerable students or vulnerable population. Like for example, someone let's say a pupil or a student who had a psychomotor delay. Yes, someone who like kind of needed special attention, but with the pandemic, this was now difficult because confinement, barrier measures. So it was kind of very difficult to handle such situations. Also, students also who were not very familiar with video conferencing, that is online platform for education, had faced some difficulties in the initial phase to adapt to learn through these avenues. The same also with the education, we know that in most institutes now, training student is not all about just going to class and having a lecture. They are also, like, for example, there's social services counselors who play a great impact in the various institutions to help the students acquire knowledge. But with the pandemic, there was a kind of a big limitation now for these counselors or social service workers to have access to these students so as to help them and contribute to their education. Thank you.
Thank you so much for that answer, Virgil, and thank you for highlighting the impact COVID-19 has had on vulnerable student populations who perhaps previously we didn't know how the current systems were designed for them. So thank you for highlighting that. Following on from that question to Dr. Hangwei-Pin, what do you think that us as medical and surgical trainees and medical students, are we prepared for a pandemic like this in the future? Are we preparing ourselves in terms of education for a pandemic in the future? And if not, how could we change our systems to prepare for such a pandemic?
So I think in practicing medicines is by nature is actually prepare for the unprepared. And, throughout the history, we have a lot of things that actually taught us hard lessons, Spanish flu, Ebola, MERS-CoV, SARS, the recent, even HIVs and the recent COVID-19. And we are kind of being better throughout the lesson that we learn. And I think this is actually important core value that how medicine should be like, student and trainee are always should be ready to adapt the changes. And if we are not ready for that, then we can't do anything to prepare for that. So just like I was saying, never let a good crisis go to waste. Throughout this COVID-19, we are about to ask ourselves, is the accessibility to healthcare achieved after the pandemic? If the ventilators are available throughout the world, even across the LMIC countries, is the vaccines, available to also the LMIC country, how the vaccine nationalism is actually creating problems to us, how was the importance of a One Health, planetary health, environmental health, and global health actually help us to prevent or mitigate the pandemics in the future. And all the social injustice, racism, and also gender inequity, it's actually how we prepare our system to be more resilient to the next pandemic. And also how was we going to empower our people to have more health literacy to prevent more misinformations or infodemic happening. So those are the questions we have to ask ourselves. Are we prepared for the next pandemic? Are our system actually prepared for the next pandemic? And how we prepare our system to be ready for the next pandemic? And yeah, this is a mentality I think we should have. Multidisciplinary and also across the whole world. Thank you.
Thank you very much, Hung. And I think those are some really interesting points, and hopefully we as students and trainees can take that critical approach with us forwards into our practice. So our next question is again for Rohini. How has the pandemic impacted your approach to medical training? And if so, how?
My approach to medical training has definitely become more proactive than passive. In India, we are not very empowered as medical students to actually talk about issues that we are affected with. One example that also kind of the question you asked to Dr. Weepin recently. So if you have to bring a change in the medical system, you have to involve the right stakeholders, which are medical students. So for example, the medical education system is structured in a way that we are not really asked if we're happy with it. And in our college, this might not apply to all medical schools in India. We are taught the basic life support course of CPR at the end during internship, when it should be taught in the beginning. So we actually had to advocate that to our administration that, hey, this is something potentially life-saving and we need to be taught this as soon as we enter medical school. And I'm glad we did that because one of my batchmates also, he suffered a cardiac arrest while we were at a field trip. And thankfully someone knew CPR and we were able to save him, but then that's what got the ball rolling to make them understand that this is something that needs to happen from the first year and not at the end when you're about to leave medical school. And similarly, during the COVID situation, if anything, that is just a personal opinion, I feel we should not shy away from being political and that the time to be apolitical is over as medical students. So taking on these changes, being more proactive, talking to the administration, realizing that if you don't say anything and if you don't voice your opinion on something that you have a problem with, no one else is actually going to understand that you're suffering and that a change needs to happen. And I kind of see and I hope that the future medical students are actually going towards a more proactive approach towards their own medical education and taking things into their own hands.
Thank you so much for that answer, Dr. Rohini. It was great to hear how the shift has been from being just a passive learner to actually taking control of your medical education. So our last question to Dr. Priyansha is, following on from that, what changes would you prioritize in surgical systems coming out of the pandemic? So what would you want to see changing in how we deliver surgical systems based on how the pandemic has impacted us?
So that's actually a very interesting question. Thank you for the same. So the approach towards surgical practices right now in India, I could give an example of India. We follow a set of protocols which either from the Royal College or not based in India, not developed in India, not based on researchers in India. And right now, during this pandemic, we did a study led by Dr. Anita, wherein we found out the changes in the emergent and the total surgical cases, and we differentiated them based on the priorities. And we, felt that there are a large number of surgeries happening in India, and there's no set protocol for it, to be particular. And after this pandemic, I believe that our focus on handling the emergent surgeries as well as the elective surgeries in a more structured fashion should come about. And by what I mean by that is, for example, triaging of patients is something which is extremely important. And right now, with the limited facilities that we have, and with the number of cases now, as we've discussed in the past couple of speeches as well, that the burden, the surgical burden, is definitely going to increase, and we're in fact seeing it on ground. So with that increased burden, moving from COVID patients, just after the COVID in the short term, we'll have to start triaging the surgical patients as well to handle such a huge load. And post that, we would probably hopefully be able to develop a protocol on how to handle the surgical cases. And with this, we can hopefully reach out to more rural areas and get access to more people who don't have access to surgery. Thank you so much.
Thank you, Priyansh. And thank you to all of our panelists for a really, really interesting discussion. I think there's a lot that we can learn from what you've said. We'll be moving on to our next session now. But yeah, thank you to all of you. I'm looking forward to the rest of the webinar.
Thank you, Katya and the Incision team for the lovely panel discussion. I'm Delphine. I'm one of the not ENT, well, I am ENT, but I am also a GASOC events representative for GASOC. And it's my pleasure to introduce you to Dr. Alex van Dweden, who has experience working within Sierra Leone, where he helped to set up Kappa Care, a surgical and obstetric task force or task sharing initiative. And he's currently doing a PhD in the Norwegian University of Science and Technology. He has participated in the evaluation of the effect of COVID and Ebola on the healthcare system within Sierra Leone, and he's going to give us a talk about that as well. Please feel free to type in the questions during the talk and we'll answer the questions soon after. Okay, Dr. Alex van Dweden.
Thank you so much, Delphine, for your kind words. And thank you for inviting me to present the experience from Sierra Leone, both from the Ebola crisis and the current COVID crisis. I will share my screen and I hope that everybody can see it. Yes. So I would like to take you to Sierra Leone. It's a country in West Africa, surrounded by Guinea in the north and Liberia in the in the east and the Atlantic Ocean. It has a population of about 8 million people, and it suffered from a civil war between 1991 and 2002. It's one of the poorest countries in the world, with a gross national income per capita of about $1,000, and it is very low on the Human Development Index. In terms of health indicators, the under 5 mortality rate is very high, with about 110 children dying per 1,000 childbirths, and has one of the highest maternal mortalities, with about 1.1%. There's a huge shortage of health workers. The whole country has about less than 10 specialized surgeons. It has about 2 national obstetricians and about 2 anesthesiologists. And there's a huge unmet surgical need, estimated to be about 91%. So in 2013, the West African Ebola epidemic started. It started in the area where Guinea, Liberia, and Sierra Leone come together on the Guinean side. And in week 14, in 2014, the first cases in Sierra Leone were detected. In total, during this period from 2013 to 2016, more than 28,000 confirmed cases were registered, and about 14,000 of them in Sierra Leone. In total, in these 3 countries, more than 11,000 deaths were registered related to the infection of the Ebola virus, and of those, almost 4,000 in Sierra Leone. And about 10% of all the health workers died during this period. So in May 2014, the first case were detected in Sierra Leone, and a few months later, the WHO declared the Ebola situation as a public health emergency. As we were running a training program during the time, and all our students were not allowed to practice, we used that opportunity to assess the impact of the Ebola epidemic to the health system. And we did it by going around to all the hospitals and accumulated weekly data on non-Ebola emissions, total volume of surgeries, cesarean sections, and inguinal hernia repairs was collected. Both hospitals from the public and the private sector were participating in this study. And the first part of the study was done retrospectively, so that we could compare to the situation before the Ebola epidemic started, and then we did it on a bi-weekly basis. So 42 hospitals were identified providing surgical services, and we were able to involve 40 of those hospitals in the study. And here you see the country, and that there were 3 different types of hospitals: governmental hospitals, private for-profit hospitals, which were mainly based in the larger cities, and the non-profit hospitals, which were mission and NGO hospitals, and most of them were willing to participate. So if we look at the effect of the crisis, we saw a 51% decrease in non-Ebola admissions during the period. So if we look at the graph, the gray bars are the number of Ebola cases, and then the lines represent the 3 different sectors. So the governmental sector is the first line, and then followed by the private non-profit sector, and the lowest line is the private for-profit sector, which has which has the least amount of admissions. So we also saw that the governmental hospitals experienced a smaller reduction compared to private non-profit hospitals, 45% versus 60%. When looking at the number of surgeries during this period, we saw that there were 41% fewer surgeries performed compared to before the outbreak. And we also saw, especially in relation to cesarean sections, that the governmental hospitals were able to increase the number of cesarean sections and thereby absorbing the decrease in the private non-profit sector. When looking at all surgeries, so both elective and emergency surgery, we used hernia repairs as an indicator for elective surgery. And we saw a big drop in elective surgeries. And this is shown on the left graph, where hernia repairs, the proportion of hernia repairs per are shown by both the governmental and the private non-profit sector. And on the other hand, on the right side, we can see the cesarean section deliveries as a proportion of all deliveries, and that increased during the same period. So here we see actually the same as was described from India and from Ethiopia, that the focus went to maintaining the emergency system and the elective surgery were put on hold. So based on the experience we had with the data collection from the Ebola situation, we also wanted to see how the impact was from the COVID situation in Sierra Leone now. So the current COVID situation in Sierra Leone is that there are slightly over 4,000 confirmed cases in the country, 79 registered deaths, and currently 80,000 vaccines have been administered, as published today by the WHO. The first COVID case was detected in week 14, 2020. So if we compare this to the Ebola situation 5 years before, we see that with the numbers today, the number of confirmed cases was more than 3 times higher, the number of confirmed Ebola cases. And if the number of registered deaths were almost 150 times more compared to more Ebola deaths compared to the current COVID situation. So it was a completely different magnitude, the Ebola situation compared to the current COVID situation. So to assess the impact on the health system by the current COVID situation, we did a mixed method study where we started a retrospective study of nationwide hospital admissions and surgical activity, and then followed by interviews with healthcare workers and patients. Hospital data was collected from January 2020 until the end of the third quarter and the end of September. And qualitative data was collected between October and December 2020. And this was done after the preliminary analysis of the hospital data in order to be able to execute the explanatory sequential design approach. So from the Ebola data collection, we knew that the private for-profit sector was very small and had very little impact on the total numbers, and therefore we decided to leave these out of this data collection, as this was a very difficult data to obtain anyway. So from the 40 selected hospitals, we managed this time to get data from 32, but those 32 did most of the activity in the country. So looking at the results, first of all, we looked at admissions by gender. comparing the first quarter to the second quarter. In the first quarter is the period before the start of the COVID. The first detected COVID case in Sierra Leone, and the second quarter is the start of the epidemic in Sierra Leone. And then we found that from quarter one to quarter two, there was a significant decrease in nationwide weekly admissions from 2,260 to 1,842, which was almost a 15% decrease. Male admissions were reduced by 18.8%, and female admissions reduced by 12.5%. So if we look at admissions by the different wards, we saw that from quarter one to quarter two, the mean weekly admissions for surgery decreased by almost 50%, while medical admissions decreased by 29%. And pediatric and maternity admissions did not significantly change from quarter one to quarter two. So if we compare the two hospital sectors, so the blue line is the governmental sector and the red line is the private non-profit sector, then we saw a reduction in admissions in both sectors, but less in the governmental sector, 13% compared to 19% in the non-profit sector. And the same accounts for Q3, where this was 12% and 60% respectively. So if we look at number of total operations, deliveries, cesarean sections, and hernia repairs, as you can see in the graph, from quarter one to quarter two, the total number of operations went down by 14%, and the number of hernia repairs went down by 60%, while the number of cesarean sections showed an increase by 12% and 7.5% in quarter three.
Sorry, Dr. Van Dwenen, we just need to speed up a little bit more. Do you have any last words for the presentation at all?
Yes, I will skip over the qualitative part. So then I will skip to the conclusion. The Ebola and the COVID had a huge impact on the hospital utilization. Planned surgical services were more affected than emergency services. Private facilities were more affected than governmental hospitals. And the decrease during the COVID crisis was less than we've seen in other settings, as discussed today, like Ethiopia and India. And there's also less than has been observed during the Ebola epidemic. Incorporation of maintenance of essential health services as an explicit aim of the outbreak response might have been helped to mitigate a larger decrease in hospital utilization. So I think I just want to say one last thing, which is what has been the impact of the Ebola and the experience with Ebola on the COVID in Sierra Leone. I think first of all, there was a lot of fear during the start of the COVID that it would be the same situation as during Ebola. So everybody took it very serious and was really afraid, and therefore the impact in the beginning was much higher. But when people realized that it did not have the same impact, people became more relaxed, and things were quite fast back to normal. On the other hand, the Ebola situation has prepared the country for epidemics like the COVID, including a referral system and an ambulance system that has been improved after the Ebola epidemic, and also identification and monitoring of cases was the organization of that was still useful during the COVID epidemic. what has been very important to see the resilience in the governmental sector, and that has helped also a lot during the COVID epidemic. And I think the main question, as was mentioned already before, is how to prepare for the next crisis. And I think we also need to realize that we're not completely finished with the current COVID situation, and that still we can see new waves coming. Thank you.
Okay, thank you so much for your talk. If anyone has any questions, just feel free to put it in the chat box. I just wanted to ask, so you were stating how Ebola is a completely different game to COVID-19, and how it was not in a bad way, but like preempting COVID-19, where you were actually a lot more prepared than you would have otherwise. So in terms of just the morale of the team, how did it affect, from what you experienced or from the local team that you were in contact with, how did it affect them seeing it happening around the world before it actually got to Sierra Leone?
I think if we go back to the first figure, then you see already the impacts starting weeks before the first case came to Sierra Leone. So people were aware that this was a pandemic and was coming to Sierra Leone, and also I think the effect of already travel restrictions, etc., had an effect on the care in Sierra Leone. But I think mainly the fear that the virus was coming had already impacts on the number of admissions and health service utilization. Yes.
So we've also got a comment from Noel, which says, do you think that the HIC or high income countries may have taken COVID situation less seriously, especially based on our points on fear and resilience and preparedness?
What I think is that the difference between the Ebola and the COVID in terms of international assistance. During the Ebola, there was a lot of focus on assisting the 3 countries in West Africa, and there was a big fear that the virus would spread to the US and other high-income countries. Now we are all facing the same pandemic, and there's actually less resources available for assisting low-income countries from high-income countries. So in that sense, the fact that this is affecting the whole world also means that less financial resources are available to assist the low-income countries, and that might suffer longer than necessary.
And then we've also got a comment from Anita, which says, amazing work, Alex, in both crisis situations. It's difficult to get data from low and middle income countries where the records keeping is a huge task. So are there any other questions at all? I mean, I'm happy to roll along and ask more questions to you, but I don't want to get greedy if anyone wants to ask anything else. Okay. So I just wanted to ask about Kappa Care and how the initiative was impacted by the COVID-19, if there was any changes to the practice at all, anything like that.
Yeah. I think during the COVID-19 situation, in the beginning it was unclear the effect on the program. So we decided, so normally we enroll students every half year. So we decided to hop over one batch in order to be able to have enough focus and enough exposure for the students that were enrolled in the program. But as you could see in the presentation, that after Q2 and especially after half a year, things started to become more normalized. We were able to continue the program as planned. Well, during the Ebola epidemic, if I remember well, we had to stop the program for more than 1.5 years. And that had a huge major impact of the whole training. So what I see what's going on in some of the other countries now is reminding me more to the Ebola situation. and the impact of Ebola than what we're seeing now with the COVID, which is not currently not the biggest challenge for Sierra Leone. And on one of my first slides, I showed that there's about 90% unmet surgical need in the country. So the need is still huge, and that this is of course unchanged through the COVID situation. So there's still a lot of work to do there.
Thank you so much for your talk and answering questions as well. I'll hand it over to the next part of our webinar, which is a panel discussion on equity and advocacy.
Thanks very much, Delphine, and thanks very much, Alex, for that brilliant talk. I'm just going to invite Dr. Matthew and Natalie, and I'm also requesting all the other panel members and moderators to put their cameras on as well, so we can just keep this as an interactive discussion about equity and access for surgical anesthesia and obstetric care. So I'm just going to introduce you to our next panel members. So we have Natalie Shannon, who is a current Masters of Business Administration, Masters of Public dual degree candidate at University of Illinois at Chicago. She's focusing her studies on social impact measurement and finance for global health and development. She's also co-president of the UIC chapter of Net Impact, an international student organization committed to business for social good. Previously, Natalie worked for the Institute of Global Health at Northwestern University, where she coordinated education programs and fundraising and conducted research on global health ethics and educational best practices. So prior to that, she worked for Northwestern Medicine and for Food and Agriculture program at the Chicago Council of Global Affairs. Natalie attended Carleton College, where she earned a Bachelor's of Arts degree in International Relationships. And we have Dr. Satish Matthew. Dr. Matthew is a retired consultant pediatrician and the National Vice President for the British Association of Physicians of Indian origin. So in this role, he has done a lot of work in improving the life of Indian doctors in the United Kingdom. So he's passionate about eliminating discrimination in the workplace. And this includes taking a lead role in the Bapio court cases where the Supreme Court ruled in favor of in their favor in the HSMP case against Department of Health, and the Bapio High Court case against RCGP about differential pass rates in their clinical examinations. He took a lead role in creating Medical Defense Shield, which is both a trade union and the medical defense organization, which is the only one of its kind in the United Kingdom. So thank you both of you for attending this this discussion. I think what we would like to hear from you. So Natalie, you are part of an international advocacy group, and based on the discussions of our invited speakers and panel members, your perspectives in how we can improve on advocacy in surgical anesthesia and obstetric care following the COVID pandemic. And we would like to hear from you, Dr. Matthew, that on, Bapio has been an excellent example of advocating for what's happening with COVID situation in India right now, and you have been involved with fundraising and lots of other advocacy work. So we'd like to hear from you, what was the drive for Bapio to get involved with this advocacy work and helping the COVID situation in India, and how we can learn for any such future situations that we may come across. So we'll start with Natalie and then we'll move on to Dr. Matthew.
Thank you. Hi, everyone. So as Noel said, I'm the Advocacy Associate for the G4 Alliance, which is based in Chicago, but really is kind of a virtual international organization for advocacy. We're a coalition of 60 member organizations representing civil society. So that includes universities and academic centers, professional societies, many NGOs, and some other coalitions like us. We are committed to advocacy for universal access to safe, timely, and affordable surgical, obstetric, trauma, and anesthesia care. And we're very pleased that GASOC is one of our active members, participating in our monthly update calls and our working groups. And basically our sort of theory of change for advocacy is based on building a strong civil society that applies pressure, but is also an ally for government-led capacity development for surgical care. And I'll just talk a little bit about what we've been doing over the past year during the pandemic, and highlighting an example from some advocacy in the United States. So in the US, the G4 Alliance and one of our working groups, our US Government Resource Mobilization Working Group, has been active in getting language on neglected surgical conditions into the appropriations report for our fiscal year 2021 budget for the government. And this is an effort that preceded the pandemic. For fiscal year 2022, we're now aiming higher and trying to secure, along with this recommendation for work in neglected surgical conditions, we're trying to secure funding of $100 million US dollars for the US Agency for International Development, which of course is a drop in the bucket of what's needed globally, but an effort that's we're thinking is like an incremental progress. But what we've been experiencing, and we're getting this message from a lot of different sources, is that most of the available funding for global health is going towards COVID-19 response, and that putting money towards surgery means taking it away from something else. And I think that's really kind of a reflection of the larger challenges that we face in international advocacy for global surgery, and especially that's the case during the pandemic. So what I see is really two problems that we're facing. One is this attitude of scarcity. I think it's fair to say that in the past 15 months, what we've seen is a health system collapse around the world in the face of a virus that was predicted. We knew something like this would happen. This is clearly not the moment for donors, including donor governments like the United States, to shy away from global health investment. You know, on a global scale, while the numbers that go into development for health look big, they're actually a really small proportion of government budgets, and most governments aren't spending enough on healthcare for their own citizens. So that's one problem. And then the second problem is that there's this misperception that spending on health is a zero-sum kind of game, that the pieces aren't all connected. So this is happening on a global scale. We're seeing countries hoarding vaccines and supplies, but then it also happens on an issue level. So I think most of us are very aware, and this has been highlighted by the panelists today, that thinking about surgery within a silo is a really unrealistic way of viewing the health system. And so our approach to advocacy during the pandemic, advocating for global surgery, is about introducing and reinforcing this idea that investing in healthcare isn't a trade-off between infectious disease preparedness and everything else in the health system. It's not an either-or kind of situation. And our strategy has really been, one, drawing out those specific links between the systems that are responding to the pandemic and the ones that are providing comprehensive surgical care. And a good example is training in infection prevention and control. Doesn't have to be just pandemic specific, just COVID-19 specific. That's something that's valuable for surgical care as well. Same with, as people mentioned, supply chains for oxygen, pre-hospital care. These are all areas where governments can get sort of a better return on their investment when they're able to think long-term beyond the pandemic, about what other needs can be met. And we know that there's urgency for all of this, ending the pandemic, addressing ongoing surgical needs, addressing backlogs, and also preparing for the next pandemic. So that's kind of a message we've been trying to get out. It requires, I think, a lot of creative thinking on this topic. And I'm not a healthcare provider, so I rely a lot on our members to think about these issues, think about those overlaps, and help us identify that and highlight that in a larger global health space. And then finally, the second part of our strategy is working in partnership with other organizations, other individuals who are advocating for things like health system strengthening, preventing and managing non-communicable diseases, supporting the health workforce, and decolonizing global health. So, collectively, we have to build political priority for health and for healthcare, and to create awareness of the data on burden of disease, and then also at a fundamental level, promote these non-negotiable shifts, power shifts that need to take place in order for any program or any investment to be effective. So I think of it as growing the pie and maximizing our value per slice of the pie. So that's kind of I would say, the broad summary of what we've been working on this year.
That's fantastic, Natalie. That's a lot of work that G4 and yourself have been doing in terms of promoting advocacy for surgical anesthesia obstetric care. Clearly, it's not an easy task and hitting the wall at times, but you keep going, and that's the best part. And I'll come back to you with one more question unless somebody else has a question for you. I'm just gonna go to Dr. Matthew and hear from him sort of BAPIO's drive to help India in this COVID situation as a group of physicians based outside India. So what was that drive that we can learn from you as sort of advocacy enthusiast? Although the focus is on surgery, anesthesia, obstetric, there are a lot of things that are translatable.
Thank you. First of all, greetings to all of you from the British Association of Physicians of Indian Origin. And thank you for inviting me to this meeting. BAPIO is the largest membership organization for doctors of ethnic minority in the United Kingdom. COVID has created havoc, not only in India, but all around the world. We couldn't just stand as onlookers. That is our motive for doing this work. So what have we done for India? As soon as actually the second wave struck, we started a platform to collect funds to help India. We collected a significant sum of money as well as equipment in kind. Now, what did we do? We supplied this equipment to various needy places in India. It was a huge logistical effort. So the equipment that was bought and collected went to the warehouse of Indian High Commission in London. It was airlifted by Qatar Airways, which was done free of cost. And when the equipment reached Bombay Airport, Indian High Commission helped us with the customs. 5 Ashok Leyland trucks were waiting there for the equipment to be taken to various parts of India. Ashok Leyland is actually Hinduja. You all know of Hinduja. They've got a charity called Mukul Madhav Foundation. So we partnered with Mukul Madhav Foundation, who helped us with the transport within India. Now, it is important actually, we did not use governmental agencies to deliver our goods in India. We wanted it delivered to the place where we thought were needy. And actually it was taken directly by Ashok Leyland Trust to the places that needed them. Now, not only did actually we supply with the equipment, we followed up. We made sure that the equipment was being used properly. And actually, we've got a lot of volunteers who actually phone these people whom we have supplied with the equipment to make sure that this is being put in use adequately. Now, the other thing that we did is actually we still provide food to the poor people in India. For that, we have partnered with various charitable organizations. The main one is called Akshaya Patra. The meaning of Akshay Patra in English is a food bowl which is never empty. We also partnered with a charity called Hope because Akshay Patra does not have reach in South India. We mainly concentrated in tribal areas to give food. We provided food kits lasting 1 month to COVID affected families. The other thing that we do is teleconsultation. Out of that, 2 things we do. We report CT chest of patients, CT chest done in India of patients there. We're trying to help the overworked Indian doctors there. The most important thing that we do is actually we do virtual ward rounds. What it means actually, we have partnered with various hospitals where we, with junior doctors, do virtual ward rounds. Actually, the responsibility of the patient remains with the Indian doctors. There was one important thing that we wanted to make sure, actually, we were not taking over patients of doctors in India because Indian doctors are highly skilled. We did not want to be a competition for Indian doctors, but we wanted to help them because they're tired, they're working day and night. And the other thing that actually we were able to do is because we have our own organization called Medical Defense Shield, we provide indemnity to all these doctors who are volunteering to provide teleconsultation service. And finally, we were able to do all this because there was plenty of volunteers who wanted to do this work, who still we are not able to give them work. And let me stop there. If you have questions, I'll come. I'll answer them. And let me tell you, actually, I am a retired doctor, not an academic. So if you ask me academic questions, I'll divert it to the eminent academics here.
Thank you, Dr. Matthew. It's amazing to see this drive that PAPU has had to support the doctors in India, but also have a sort of pathway planned in such a systematic way to ensure that things get delivered as planned. So I'm just going to open it to the floor if anybody has any questions to our panel members, because I know we are sort of just overrunning slightly. We've got another 5 minutes before we wrap up this webinar. So if anybody has any questions for Natalie or Dr. Matthew, anybody present, it'll be great to just get that out. Yes, Burjo has a question.
Thank you very much. My question is like, presently I'm a medical student, and what I've noticed that due to the pandemic, many patients, like let's say patients who come with surgical pathologies, most of the time they come as emergencies as compared to before, whereby you had at least some who come electively, but now most of them, they don't want to come to the hospital. They usually come maybe when it's already like the disease is already at an advanced stage. So I don't know which piece of advice will you give me so that I can help to educate the population, so as to encourage them, I don't know, to come to the hospital at the appropriate time, not just waiting when it's already kind of complicated before they come to have care. Thank you.
That might be a good one for Dr. Tadessi to answer, because Dr. Tadessi, you mentioned you were having the same issue in Ethiopia.
So pardon, Rima?
Just in terms of how are you encouraging people, Dr. Berger mentioned how are you encouraging people who are known to sort of be late presenters or discouraged from going into hospital because of the COVID crisis? How are you encouraging them to come earlier? Do you have any tips?
That's a good question. Yeah, so it's one of the big problems we're facing as well, like decreased patient health seeking behavior. So I think the main thing we're trying to do is just through public awareness, as much as possible, try to get the information, the right information, and to, as much as possible to stop these misinformations and just avoid that confusion and through public awareness. Yeah.
Yeah, it's difficult, isn't it? I think a lot of this is sort of government led, especially when you're trying to get information out to the masses.
Yes.
I had a question for Natalie. In terms of there are a few people asking questions in the Q&A as well, so please look out for that as well, and if you could answer that. But in terms of advocacy for surgery, anesthesia, and obstetric care, pre-COVID to post-COVID, how do you think we can be more impactful in increasing the advocacy drive for universal health coverage as a group of enthusiasts who are discussing these vital aspects? And also one more point that has been mentioned, and we've especially heard from this amazing Incision UK panel, that there is a drive amongst the emerging leaders from LMICs as well as high-income countries for this same goal of achieving universal health coverage. Is there a sort of more uniform approach in how this advocacy can be driven, that it's just not a lot of talking, but actually a lot of action, which is what Dr. Datta also mentioned?
Yeah, no, that's a great question. I think something that was important to people who were talking about health systems before the pandemic has only become more important now. I think more people are sort of conscious of this relatedness between different aspects of the health system, and they're, recognizing that, as I mentioned, working in silos just isn't a realistic way of promoting resilience. So I would say from a trainee perspective, a lot of what is really valuable, I think if you're interested in advocacy, if you're interested in this type of work, it's, trying to sort of de-silo your own work. And I know that everyone is so busy. You're busy with your school, you're busy with life, there's just ongoing things with the pandemic, but I think that it's really helpful to to think about a topic that's interesting to you that may sort of fall outside of your training. I mean, it could be something like food security or labor rights or gender rights, reproductive health. You just need lots of people thinking about the overlaps, trying to take the systems thinking approach. So what I would say is find a topic that's interesting to you, spend some time doing a deep dive into that topic, and think about what are the relationships to surgical, obstetric, and anesthesia care from your perspective. People really do want to hear from students, and they want to hear from trainees. And I'll just add that at the G4 Alliance, we have several working groups, but in particular, our advocacy working group is really trying to take this approach, thinking outside our silos. And we've been working on creating several policy briefs for other high priority global health and development issues, and using the writing of those policy briefs as an opportunity to do outreach with other organizations, to build our network, build our relationships, so that we're this sort of Greek chorus saying, invest in healthcare, invest in health systems. But we can't do it alone, and we need lots and lots of people working with us. So my ideal situation would be to have, every trainee who's interested in health system strengthening to join our working group and participate with this effort, because we need lots of creative minds thinking about these problems.
Fantastic. I mean, that's excellent. Thank you very much for your insight in the situation. I think, unfortunately, I think we can go on for another hour, but I think we need to call it a day. It's been fascinating to have you all speak and share and discuss. And thank you for all the participants who've joined in from different parts of the world. It's so good to have you. I think the mixture of talks and discussions have just led us all to just think again. As Natalie said, we need to just think together deeply, have a deep dive in how we can improve our advocacy efforts. And also like people like Dr. Matthew and the organization BAPIO, who recognize there is a problem and come up with solutions to help that situation. And virtual clinics and stuff that he mentioned is amazing. I mean, COVID pandemic is right in our face, and that's why people are feeling that they need to do something. But we know that 5 billion people, sorry, I have to use this word again, 5 billion people do not have access to surgical care. And probably, I'm not sure if the universal health coverage we are going to achieve by 2030 as planned by the United Nations and WHO following the COVID pandemic. So there's a lot of work to do. There is a lot of unity to happen and collaborations to take place. But also we need to hear what are the LMIC voices saying, and they need to be involved in discussions. It's not the people who are based in the high income countries. The discussions have to be led by those who are in the low and middle income countries by forming partnerships, collaboration, and friendship. So it's so good to have you all today. Thank you very much. If you have filled in the registration form, then we will be sending out the certificates to you. If you are interested in contacting any of the speakers, do reach out to us and we will contact you. And this recording we're going to try and put on our YouTube channel, so you can have access to it 24/7. Okay, thank you all and have a good day, evening, good night. See you later. Bye-bye.
Thank you, everyone.
Thank you.
Bye.
Thank you, everyone.
Thank you.
Bye-bye. Thank you, everybody.